Professor Hani Mwafi, the current president of the Egyptian Orthopaedic Association, and Professor Ramesh Sen from India, the the former president of the Indian Orthopaedic Association. We have two in every webinar. It will be on Friday at 10 p.m. Cairo local time, 8 p.m. Cairo local time, 10:30 p.m. Indian time, because we are in the summertime in Egypt. So the difference is 2.5 hours, not 3.5 hours. So we can, there will be no problems with joining from India, I think. We have two speakers tonight. First speaker will be Professor Lalit Maini from India. He will speak about 3D printing in orthopedics. Second speaker will be our Professor Gamal Hosny, the former president of the Egyptian Orthopaedic Association. Professor Hosny will speak about 3D printing in deformity planning. First, I would like to welcome Professor Adel Al-Adawi, my dear professor, to announce for the official beginning of this course. Professor Adawi.
Thank you, Dr. Muhammad Al-Ashhab, the Dean of Banha Medical School, Banha University. Thank you for this innovative idea, you and Professor Servinas. I'd like to welcome all of you today, my esteemed colleagues, Dr. Ramesh, Dr. Maini, Dr. Gamal Hosny, Dr. Hani Mwafi. Welcome all of you in this revision course, our orthopedic review course that organized by the Egyptian Medical Association and the Indian Orthopaedic Association. I hope that this course definitely will mark an important milestone in our collective mission to advance the field of orthopedic surgery. As we come together here to exchange our knowledge, ideas, and experiences in this virtual platform, I hope that, as Dr. Ashhab said, over the next sessions that will be held in every Friday, all the attendees will have the opportunity to participate in a diverse array of sessions that cover all subspecialties in orthopedics, from joint replacement to spine surgery, from trauma to sports medicine, and much more. I think that our attendees will learn from our expertise, well-known orthopedic professors in all fields of orthopedic surgery. As we continue to adapt to the unprecedented changes in healthcare delivery in general and the medical education and training that we have faced with the COVID-19 pandemic. This course represents a pioneering effort to harness the full potential of technology to overcome barriers in education and training. I'd like to thank you again, encouraging all our attendees to actively participate in the interactive sessions, engage in discussion, our colleagues, and ask questions to the faculty through the chat box, as Dr. Ashhab told me. And let us use this platform to connect and to collaborate, to share our knowledge, experiences, and to collectively advance orthopedic care definitely for the sake and the benefit of our patients. Once again, welcome you again to this course, and I wish you a fruitful discussions and valuable insights. Great regards to all of you, and this is a very good step, Dr. Ashhab, Dr. Servinas, that we should continue and build on it. Thank you very much.
Thank you so much, Professor Adel, for the announcement of the official beginning of this course. Now we will have Professor Hani Mwafi, the current president of the Egyptian Orthopaedic Association. Dr. Hani.
Okay, thank you, Dr. Ashhab, and also Dr. Tnaz. I would like to take a chance to thank your idea about this course, and I would like to, with Egyptian Orthopaedic Association and also Indian Association, and I think it is a very good chance to to get the experience or exchange the experience between Indian doctors and also Indian experience and also Egyptian expert in this field. And I would like to invite all Egyptian orthopedic surgeon to get this course, which is actually it is a very excellent or a good chance to for them to get most of experience between the expert doctors in Egypt and also in Indian. Thank you, Professor Ashab, again for this effort with and also with Indian colleagues. And I would like to invite all Egyptian surgeons to take a chance to take this chance for learning this course. Thank you, Dr. Ashab. Thank you, Dr. Sinis.
Thank you so much, Dr. Hani. Now we come to the Indian side, our dear professor, Dr. Ramesh Sen. Dr. Ramesh.
So, respected Professor Adel and other office bearers of Egyptian Orthopaedic Association and all members of this association, I'm really honored and extend a warm welcome to all of you on behalf of Indian Orthopaedic Association. Just last December, as I was just discussing, I had the opportunity to be there in the annual meeting of Egyptian Orthopaedic Association, and I'm really impressed by the scientific standards of your meeting. It gives me immense pleasure to again connect with you right now through this virtual platform for the launch of this weekly webinars, so intelligently planned. I think will have a long-term benefits for all of us. As healthcare professionals, we understand the importance of this knowledge sharing and continuing education. And this, as was told by initially also, that there has been a pandemic, and this pandemic has made the virtual meeting as a new norm. So we are excited to collaborate with our colleagues from Egypt to bring a series of these informative and engaging webinars. This, our joint effort is to organize this webinar is likely to serve a platform to share knowledge and experience from the experts in the field of orthopedic surgery. We do hope to enhance this mutual understanding and strengthen our bond through this collaboration in this journey of continued learning and professional development. Thank you and best wishes for the successful series of these webinars. Thank you.
Thank you so much, Professor Ramesh. Thank you so much, sir. Now we will start the webinar. Dr. Srinivas will introduce our dear Indian speaker. Dr. Srinivas, please.
Good evening, everybody. First of all, I would like to thank the Egyptian Orthopaedic Association and Professor Adel Adawi and Professor Hami El Mafi and Professor Gamal Hosny and Professor Muhammad El Ashab for giving me this opportunity. I'm honored to organize this from the Indian side. I'm very grateful to all the speakers who have kindly accepted to participate in this course. Our first speaker is Professor Lalit Maini. We all know him. He's a professor of orthopedics at Maulana Azad Medical College at New Delhi. And he's also the editor-in-chief of Indian Journal of Orthopaedics and the MAMC Journal of MAMC Medical Journal. He also is an executive editor for Journal of Arthroscopy and Joint Surgery, as well as one of the presidents of he will be speaking on 3D printing in orthopedics. Thank you, sir. Maini, sir, could you?
Thanks, Dr. Srinivas. Is my screen visible?
Yes, sir.
I extend warm greetings from Indian Orthopaedics, specifically from Indian Journal of Orthopaedics, and grateful to the Egyptian colleagues to invite us. Thanks a lot to the dignitaries on the dais, Dr. Srinivas, Dr. Sen, to bring out this excellent thought, and let's see how we can help each other. I'm going to be speaking on 3D printing. 3D printing adding creativity, and I think that it is going to be the future of orthopedics. I will be touching few basics because still it is a newer modality when it comes into actual healthcare application. So let's see what it is all about. So we have a famous dessert which is made in India. You have quite a few in Egypt. Now this man is throwing some material into a container which has hot oil, and a dessert is being formed. So 3D printing is almost similar to this. The person is a computer and we use some material to print, and the print is decided by whatever we plan. So making it a very, very simple description of what is done in 3D printing. So if we go back to conventional manufacturing of any material, what was followed in the past was subtractive manufacturing, meaning if you have a block of material, you will use various machining tools like burrs and drills and saws, and you can see, as you can see on the top row, you will create a material which will have a specific design, the 3D object. And in the extreme last column, you can see a pile of waste which is produced at the end. Now, what is different in 3D printing? You start with a material and you layer by layer create the 3D object which you want. And that is why it is called additive manufacturing. And you can see that there is hardly any waste which is left at the end of the manufacturing. So if we have to understand the same thing using an orthopedic example, if we have to create an artificial bone, and on the top is the traditional way, the subtractive manufacturing, where you carve out a bone shape from a block of material. And in the line below is a newer technology, the additive manufacturing, in which you go from bottom-up process, meaning you go layer by layer and create the form. So let me introduce you the basic steps to do 3D printing, the actual way which it is done. So you choose a software, you do some virtual planning, or you make an STL file or download it free from the internet. There are various files available on the internet for free downloading. You load the printer with a spool of material. Now this material could be many, but here I'm taking an example of a polylactic acid, which is a plastic, and the material goes into a extruder, which is heated up. Then you take the file which you have chosen to print in a form which is called STL, and with a memory stick, introduce it to the printer. Now this is the printer which is printing layer by layer, the additive manufacturing process. It could be done in two ways. The nozzle can move in Z-axis, or the platform itself can move downwards. And practically, with time, the whole form is created. So it is a process in which 3D objects are created, and it is easy if you try it out. So three aspects of 3D printing are: you need a software to plan out whatever you want to create, you need a hardware, meaning the 3D printer itself, and you need to have the material which you decide to use. Once you've done that and you've done the whole process, you will need some amount of post-processing to get the final object. So the 3D printing technology has gone various phases of maturing, and we've almost reached probably the fourth generation of 3D printing. So in 1983, Charles Hull, the co-founder of 3D Systems, invented the first 3D printing process and called it stereolithography. So in the recent past, the copyright years have expired, and now the printers are available in the market at a much cheaper price. When Mr. Hull created the printer, it was like this. You can see a computer, a PC, and on the right side, a large platform with a very small printing area. The printing area was around 5 centimeter into 10 centimeter into 10 centimeter. And in today's era, there are printers available in which you can even print houses. So we all have been printing our pages to type our letters. So the top, you can see a printer. And on the bottom, you can see a 3D printer. Now, 3D printer, classically, the office 3D printer would be of a size of a microwave. And you create objects deciding whatever you want to create depending upon your plan. And the most advanced level of 3D printing, as I was telling you, it has gone through various phases of development, is now bioprinting. Research is going on into creating bioinks, which can actually create human tissue in the lab. Now, human tissue is already being printed in the lab. Skin is very successfully printed. And in various parts of the globe, various types of tissues have been printed, and they have been used for experiments where pharmacological drugs can be tested over these organs which have been printed in the lab. So it is something like a in vivo tissue available in vitro experiment. So I'm sure in near future, we would be printing tissues, and things like cornea banks and bone banks might disappear, and we might have 3D printed banks. So various applications, an overview in orthopedics. The largest one probably at this point of time is in surgical planning, in corrective osteotomies, in deformity correction, in complex trauma, in tumor management, and in complex arthroplasty. Definitely, it's a very important tool in research, which could be basic science related to cells, or it could be on biomechanical studies. For academics and display, for doctor-patient interaction with 3D models, and also for teaching our residents in our curriculum. So let me take you through this first step of virtual planning. The whole process of 3D printing starts from an image. And commonly in our practice, it is either a CT scan. In this example, a pelvic tumor, we've taken an image from the CT. Now we are taking the soft tissue component from the MRI. And then we use a software to extract these tissues onto a platform where we can do a virtual surgery, do a virtual planning, and execute the same planning during our surgery. So this is the pelvic tumor, and you can see that we are bringing in the soft tissue, and we will merge the soft tissue with the bony component. Once we've done that, we will mark the resection with a reasonably acceptable margin. There you see the red line coming in. And then we'll create a plate which can be used as a guide during surgery. So we just print this plate, and after exposure, we put this plate on the bone, mark the osteotomy, and complete it with minimal amount of dissection. So this is what has been done in this case of chondrosarcoma of the ileum, a type 1 dissection. If you look at the lower picture, you can see how close we are with the acetabulum. So unless we have this type of planning where we use the CT and MRI, we've done fusion imaging, we've done a planning of resection on the computer, and then created a 3D printed guiding jig. So ultimately, the 3D printing component was pretty small, but the planning part was pretty large. So the 3D printing area brings in so much creativity into orthopedics that it is up to us to imagine where all and how all can be used. I will show you a few clinical examples which I have used in my practice till date and give you a bird's eye idea on how much useful this can. So this is a clip from University of Australia in which they have introduced this project in which a tumor is being imaged preoperatively. The CT and the MRI is used for the surgical planning. We create the plan and the data is transferred to an operating robot. The resection of the tumor based on the imaging is done using a robotic arm. The resected bone is scanned by an ultra-fast scanner, and again the data is used to 3D print a similar shape and size hydroxyapatite scaffold inside the OT using ultra-fast 3D printers. So this is a dream project which is going on in Australian University, which then can be sterilized and reimplanted into the patient, and biologics can be added over it. And the final frontier, bioprinting. Now the needle has the cells and the bio ink, and it is being laid down on a glass slide, and a scaffold of a tissue is being printed. So this would be the final scaffold, final frontier of what 3D printing would achieve in times to come. So we have been planning deformities, like for this example of a tibia vara. We have been making tracings on scanograms, deciding the center of rotation of the deformity, calculating the angle, planning the correction on tracings, and then executing the osteotomies. However, if we look at deformities which are complex and multiplanar, if we have a CT scan, we can easily separate all the bones of that particular patient using softwares, and this is what is an output. So you have separated the tibia, femur, and the fibula, and you can then take it to another manipulating software where you can actually draw planes of the deformity. So we've graduated from deformity lines to deformity planes. So once we have planes, there is a possibility of doing a virtual corrective osteotomy on the computer itself and getting a perfect correction both in AP and lateral, deciding even the slope. And then whatever correction which has been planned can ultimately be 3D printed. So this yellow part, which is a trapezoidal structure, is 3D printed. And you can see a hole in that in which we can put a Shan's pin, and intraoperatively, after you have done a linear osteotomy of the tibia, you can use a distractor, gradually open the osteotomy, and then gradually insert this wedge to get an exact correction of deformity which you have planned preoperative. So another beautiful example, after correction, you hold the correction with an external fixator, take out the plastic wedge and reinsert autogenous bone graft to hold the correction. So this is the post-operative X-ray. So beyond medical life, 3D printing has changed the prototyping in all walks of industry. We have used it in understand anatomy, plan surgery, customize implants, and customize instruments. So this is a case in which it's a neglected post-traumatic hip arthritis secondary to a neglected acetabulum fracture. So the problem are understanding the anatomy, the fracture pattern, what type of bone losses are there, how to get about it. Obviously, most of us would get a CT scan to plan this. And now, in the last few minutes, you must have understood, if you have a CT scan with you, the soft copy, you can then create the real model for this patient. So here is a real model of this patient. On the left side, you can see that the posterior wall is separated and lifted off. On the right side, we've done an osteotomy in our office and reduced that wall. And to our surprise, the wall was completely falling back beautifully and just leaving some defect on the medial side. So we planned that we'll do an osteotomy, we will reduce the wall, fix it with the plate, and fill up this defect with the head graft which we get from the patient. So we had preoperatively contoured a plate on this model, which we used for fixation of the posterior wall. So that's the post-operative X-ray, a beautiful reconstruction of the hip and a total hip replaced. Another example, you can see those yellow arrows, which are showing you extra bone forming out of the femoral head, which leads to impingement, a cam type of impingement. These are severely large type of cam impingements. So when you get a CT scan, then you know now you can play with them. You can see that this is the normal femur and this is the abnormal, large osteophytes. However, otherwise, the joint was still sort of carrying some cartilage, and we can preserve this hip. So we went on to plan that how can we resect this extra bone so that we don't cause a fracture, and we do adequate amount of chelectomy to recover movement. So we took the opposite normal hip as a template and created a jig to do the resection. So this is the jig being created, both aspects, the neck diameter as well as how much has to be resected. So these are the two things which were ultimately 3D printed, autoclaved, and used in the patient when this is the 3D printed jig, when we surgically dislocated the hip. So you can see we have put the jig on the head, then we marked where the bone has to be removed, and we have been beautifully been able to recreate the plan which we had done pre-operating. That's the post-resection assessment using the second jig. We published this in the Journal of Clinical Orthopaedics and Trauma a few years back. Another interesting case, a chondroblastoma, almost in a weight-bearing area in a young female. So we decided that we'll do a surgical dislocation, we'll curate it, and we'll take mosaic plast osteochondral grafts, form the ipsilateral knee, and recreate this cartilage. So we could do the whole planning using the CT scan, and we planned that we might be able to manage using 3 1 centimeter osteochondral grafts. So we use some clay, we use the Arthrex mosaic plasty instruments to preoperatively rehearse the surgery. We went on to achieve a reasonable result, and we had a good follow-up, and we went on to publish this in the Japanese Journal of Orthopedic Science with a 2-year follow-up. Look at the beautiful follow-up MRI. It seems that nothing has been done. And that's a follow-up X-ray of 2 years. So 3-dimensional printing and patient-specific pre-contoured plates for fracture acetabulum was actually our first project, which we started in 2012. That is where our journey of 3D printing had started. We had printed 10 real-time models of patients, done the reduction, did the plating, used the same contoured plates during surgery. So you have a good, fair idea now what we would have done. We would have used the CT scan, we would have separated the fracture, we would have reduced the fracture, made the plate templates, and 3D printed the templates, contoured our plates using these templates, and finally use them in the patient. So this is one case which came 1.5 years later to us after injury, malunited proximal tibia fracture. You can see we use the CT scan and we did identify what the problem was. We reduced it on our computer, we decided that we'll need a posteromedial plate. We created a template and we printed the template. Once we printed this template, we used the routinely available plates to contour them over them, and then use them intraoperatively. Look at the beautiful reconstruction. So this has been possible because we were able to understand the problem using the virtual planning and then execute it by creating 3D printed templates. That's the post-operative CT scan. You can see all the sections, the coronal, sagittal, and the axial. We've been creating bones which needed to be replaced because of tumors. This is an example of a talus replacement. We've actually done 3 calcaneal replacements till date using this beautiful mesh structure and areas to anchor the calcaneum back. And we've also done customized antibiotic spacers, which we created using the trial implants, which the patient had been used for doing the arthroplasty. And just with the cost of the cement and a 3D printed mold, we could create fantastic antibiotic spacers. This is for the hip. So many examples. This is a jig which helps you guide placement of cervical spine pedicle screws. So you can see that the space between the canal and the vertebral artery is pretty small. You just have very little margin for error. And we recently published this in Neurology India, a series in which we use them in cervical pedicle screw placement. So that's the jig. We used to print the jig, test it on the models, and then use it in the patients. So now the future of 3D printing would, I think, go even further, and it will merge with the abilities of using these images into augmented reality and virtual reality. Here, the same plate template has been created, and then with an application of augmented reality, we can actually see the plate in thin air with the reference of a QR code. And the plate contouring, which we are doing by printing a template, now can be done even without printing a template. So this is an augmented reality assisted plate contouring, which again initiated from the image of a patient. So this is a great tool which can help you in various fields of orthopedics, from education, research, from executing complex surgeries using guiding jigs, creating new structures which were otherwise not available. And we are moving from an era of mass production to an era of mass personalization. So we've also written a book on medical 3D printing. If you go on Amazon, this is available. The editor-in-chief is Dr. Raju Vaishya from India. And we have been exploring various possibilities of creative orthopedics using 3D printing. You can visit the YouTube channel Ortho#609, where various other applications and basics of 3D printing are available. And of course, you can email me and we can definitely interact and collaborate and learn from each other on how to using this technology even more. So thanks a lot for giving me this opportunity to come on this platform and sharing with you these thoughts. Thank you.
Thank you so much, sir. Dr. Srinivas will be the moderator of any questions. I see some questions, Dr. Srinivas.
Thank you very much, sir. The talk was amazing. So many applications of 3D printing. There's one question here. How much time it takes to create a 10 into 10 into 10 cube by 3D printing? Is it model design dependent too?
Dr. Srinivas, can you please repeat it? There was some audio
The question is, how much time does it take to create 10 into 10 into 10 cube? It doesn't say the units, actually, probably centimeters, by 3D printing.
So it will all depend upon what would be the density. But if you ask me, if it's a centimeter, it would take, say, around 6 hours to create this.
Can we print metal instruments, sir, using 3D printers?
We can print metal instruments, but instruments, the issue is that they come for mass production. But when it comes to implants or when it comes to replacement, the classical example would be a talar replacement or a calcaneal replacement. That is the area where this technology has an amazing solution which never existed initially. And we are now able to do metal printing in our country, and we have been using it in our clinical practice.
What about surgical instruments, stainless steel?
We can. The material is not at all an issue. You can print in stainless steel, titanium, cobalt chrome, or whatever. That's not a challenge. Printers are available in all possible materials. In fact, gifting your girlfriend a birthday cake, which is 3D printed, is a very popular gift. And 3D printing customized chocolates is also a very popular gift.
And what is the default material you use for your regular 3D printing?
So most often we use polylactic acid, which is a plastic, and it is easy to use by FDM technology, the small printers which I told you, which each one of you can have in your office. And it doesn't cost much. So it's fast, it is easy to do, and it doesn't cost much.
And are there any disadvantages, any health risks for the surgeons, with the high temperatures involved in the material?
So the nozzle which we use typically has to melt the material which we are using. So if it is metal, it's actually a very high temperature phenomena. And all this is done in a closed chamber. So the temperature is not an issue, but definitely the dust is an issue. So all the printers today are closed chamber printers. However, even despite that, the material dust would be an issue if you're doing a lot of printing around the clock. So it is always recommended that your printer should be in a standalone room and with a good exhaust attached to it. And once the printing is going on, it is preferable that you should not be going in. That's why now we have this possibility of remote monitoring your print process. So the printers have small cameras inside it, which you can remotely observe your printing process and also give a remote commands of stop and restart. So the dust is an issue, definitely.
And does the user, what level of computer knowledge do the user should have to use 3D printers?
I think anybody who is using an iPhone should be able to use a computer. Anybody who is doing PowerPoint, Excel, MS Word, and emails would gradually learn to use them. It's not a rocket science. It is not something that only an engineer can do it. I'm doing it myself, so most of us do it ourselves.
We have some more questions coming up, sir. Can you recommend some 3D printing apps or programs?
Different countries would have different. I really don't know what you have, but 3D Slicer is a very good free application, which most of you can go and start converting your DICOM images into STL files. So STL file is the one which you feed to a printer, and that gets printed. So 3D Slicer should be a good area to start with. If you go to YouTube, there are free YouTube tutorials there on how to using 3D Slicer, and 3D Slicer is a free software, so you can download and use it freely. There are others which would be paid, like the most popular one is Mimics by Materialize, which is from Belgium, but that comes with a cost and it is paid. So maybe if you're procuring one for universities, Materialize Mimics is a real good standard software. But if you are just doing it as a hobby, 3D Slicer is a good place to start.
Blender also.
Blender. So Blender is actually the next phase. Slicer, you create the STL files, and now when you want to cut and bend or create a plate and do those things, then the Blender is the next. That's again a free software.
Okay. One more question, sir. How do you see the cost effectiveness of 3D printing?
It is a very, very cost-effective technology, meaning printers now available with me are rupees around 20,000, which I use, and the material is actually peanuts. So the jigs which I print, the costing of a jig would be 100 rupees. So that's a cost when you have a printer and you buy a material. So cost is very cheap, but the cost will zoom up if you are doing metal printing. So if you want to typically print a calcaneum, the average cost could be somewhere around 80,000 to 1 lakh rupees.
Thank you very much, sir.
Thank you so much, Dr. Srinivas. Many thanks to Professor Lalit Maini from India for his marvelous presentation. Thank you so much, sir, for joining us. Now, thank you so much, sir. Now we come to the next part of the webinar. I think we have a question. I'll answer it. Now we come to the next part of the webinar. The second speaker will be Professor Gamal Hosny from Egypt. Professor Gamal, the former president of the Egyptian Orthopaedic Association. Professor Hosny will speak about 3D printing in deformity planning. Professor Gamal.
Thanks, Mohammed. First of all, I would like to thank Professor Mohammed Lashab, Dean of Banha University, for his initiative. Also, Professor Servanas, this is a great initiative. You know, for me and my Indian colleagues, we have lots of things in common. And we need to share ideas, exchange ideas, and learn from each other. We have similarities in the problem, perhaps limited resources. We have lots of things to share. So I would like to thank both of you for this great initiative. Also, I would like to thank Professor Ramesh Sen for his presence, and also Dr. Lalit Maini for the lecture. It's a great pleasure having you, Professor Ramesh Sen, after we met in Cairo, and we hope we see you again in Cairo. We look forward to. I would like to thank also Professor Adel Adawi, former former Minister of Health, and Professor Hani Mwafi, the chairman of the Egyptian Orthopaedic Association. Now I'm going to share my slide, Mohammed.
Yes, sir. It's working.
Okay.
Yes, sir.
My approach will be different. I'm going to try to convince you to change your concept from 2D to 3D or 4D even. You know, all of us have learned in one way. If you have a patient, you do plain X-ray, AP and lateral, and that's it. So judging patients with 3D ideas, all our eyes are oriented with the 3D principle. And this is not true. This is not the reality. Just I want to remind you with this webinar in the next Friday by the CCOT about limb reconstruction, about open fractures. It's going to be 3:30 p.m. Indian time in Cairo, 1 p.m. And this is the faculty, Hemant Sharma, myself, Ariji, and Samir Kumta from India also, Mahmoud from Egypt, and Dr. Gopal from UK. I would love to have all of you to register in the CCOT website to attend the webinar. As I've told you, when we have a deformity, we do AP and lateral and we draw lines. And this is the way we judge cases. We do from the center to the center, and another line from the center to the center of the hip, to the center of the ankle. And because it's going medially, we have a varus deformity, and the aim of limb reconstruction is correction of the mechanical axis. Most of the seminars, most of the workshops and courses abroad are dealing with this point. They teach you how to correct the mechanical axis. In our area, this is not true. Deformity correction is changing lives. It's not correction of the mechanical axis. You have to change the life of this patient from bedridden patients to a moving patient. And this is a huge difference. When I present cases abroad in the States or Germany or Italy or something, I usually tell them, perhaps we are not talking the same language. Because you are talking about genoverum and genovalgum, but we are talking another type of patients. It's not the mechanical axis. This is the type of patients we are talking about. They are talking about amputation as a solution. For us, for amputated foot, how to solve the problem, have to do replantation and lengthening. So it's changing lives. Are we still planning in 2 dimensions? It seems like living in the past. It's no longer true. If you are trying to judge your patients or the deformity by two plane orientation or 2D orientation, this is an open fracture femur. Tell me, if you do plain X-ray, AP, and lateral, is it going to help you? This is not true. This is a 3D problem. How can you judge a 3D problem with plain X-ray, AP, and lateral? Again, it won't help making AP and lateral. Why? This is, if you have a human being, and this is the center of a circle, 360 degrees. And this is the coronal plane for plain X-ray, AP, sagittal plane. This means 2 degrees of 360, and this is 2 degrees of 360. If you think about the deformity, why the deformity on Earth will choose these 4 degrees and ignore the rest? So 2D planning for deformities is not true. The seminars, workshops, and deformity planning courses abroad for 4 days. This is not reality. They are talking about something else. I started to think about the 3D problems when we do the closed reduction techniques. You can read this paper about the closed reduction techniques. How to reduce fracture in adults without any incision. So the fractures can be treated as 3D models. And you can also do 3D models to optimize the plate if you want to do a plate. And I will give you an example. This is the tibial plateau fracture. And the patient has CT, coronal plane, tibial plateau, sagittal plane, and transverse plane. And this is the 3D picture. Look to the surface of the plateau. It's broadened, comminuted, lateral medial. I don't know which classification. I cannot remember the classifications. Each one on Earth is inventing a classification and call it after his name. Every day you have a new classification. Forget about the classifications. This is comminuted tibial plateau, and you have a depressed fragment. And I will show you in the operating theater how to think in a 3D manner. We took the patient to the operating theater and we just do little contraction, distraction. Then we tried to raise this segment. We went from that side, then with a blunt, this sector, we tried to raise it, but we failed because we couldn't catch it. Now, with a drill hole, 4.5 drill hole in the middle, we had a drill hole, then again we pushed, we pushed this blunt instrument and we succeeded to raise it. Why? This segment was a bit posterior. And if you want to push it, you have to go posterior more. So it's not anteroposterior and lateral. Again, we have broad tibial plateau. So we compressed the tibial plateau and we put olive wires. Again, multiple olive wires and a circle here. But look, again, depression happened. Once we removed the blunt instrument, revision happened. So we removed the circle and again we pushed this blunt instrument to raise it. And after this, you see, we put many wires to support this segment. This is how we do the closed reduction techniques. You have to have 3D orientation of the fractures. The fracture is not a 2D problem, it's a 3D problem. And if you want to treat it in a closed manner, even in an open manner, we usually treat the fracture in a closed manner. You have this 3D orientation. And you see the patient who have immediate wood bearing because there are no incisions. It's closed treatment of fractures with this 3D orientation. Again, in deformity planning, people insist on the rules they invented. So you have this C-shaped deformity in one plane. And you have to do 2 osteotomies and correct it from 2 osteotomies. You see. But look to this deformity. Can you help it with 2D? Of course not. How many apices of deformities here? How many? 1, 2, 3, 4, 5, 6. And look to the lateral. Because this is not an AP and lateral deformity. This is the 3D dimensional deformity. And this picture, see angulation, shortening, rotation, 190 degrees rotation. How can you examine it? This is the 3D deformity. Again, we do corticotomy and derotation and lengthening, and this is 3D orientation and correction of the deformity. Now coming to 4D deformities. What's 4D? You have a deformity, but this deformity is not stable. After 5 days, you are going to change, the deformity will change itself. So this is the physical injury. Are you expecting this injury, this deformity to be the same after 1 year or 2 years or 4 years? So you have to add the time to the deformity. And we call it 4D deformities. This is a new expression which I created. If you want to think about deformities, you have to think about the future of the deformity. If we think about the deformity, the future of the deformity, you can add the 4D to the type of treatment you treat. How are you going to do this? I will tell you. How are you going to treat the 4D deformities. So it's a 3D printing is a process of design and manufacture. It's becoming more frequently used in surgical specialties in the recent years. And we've listened before, how would you create this type of plating for a certain type of osteotomy, corrective osteotomies. So it's commonly used in pre-operative planning, and it's also a useful educational tool. So you don't have, during the correction of deformities, to teach the people drawing lines and lines and lines. And this is not true. You can't teach them on the real models. You can't teach them how to correct the deformity, and I will show you the example. Limb reconstruction surgery continues to affirm itself as a distinct subspecialty worldwide. And what's new, I will show you. The very popular annular deformity courses, Baltimore, Hull, and Cairo. I would like to invite all of you to come to our 19th International Conference, 2 to 4 August. Please participate. We need participation from all my Indian friends. Dr. Hani is there. Dr. Hani, the chairman and the president of the Congress, is inviting all of you. We have Rosbroch from the States, Soaid from Malaysia, and Wagi from England, Lahuti from England. We have lots of guest speakers. Please come. Our thinking about the three-dimensional deformity started long time ago by this paper about TSF. And in the last American Academy meeting in March, I gave a lecture, the guest lecture, about neglected war injuries. And there was a symposium about 3D technology. And what about 3D technology? 3D printing, the prosthesis, the bioprinting. Bioprinting is very important. The navigation. And I will show you example of the 3D printing or bioprinting. It's very important. We have 3 mechanisms for bioprinting: imitative, emulitative, and transformative. Imitative create a cellularized structure that is as close as possible to the target tissue or organ. The living structure is functional at the time of implantation. It looks like putting a lever inside. Emulative create a cellularized structure that resembles the form and function of the target tissue and organ. The structure will be remodeled and become functional after implantation. Transformative create a cellular structure that contains a physical and or chemical signals for tissue repair and regeneration. The implant transforms into and promotes formation of functional tissue. This is 3D bioprinting. It's very important. Coming to the deformity planning. If you have this complex deformity and you just do plain X-ray, AP and lateral, and you have translation, valgus deformity, again translation, and some angulation, flexion deformity, it's okay. How would you do? How would you manage? You draw the mechanical axis from the center and the center, and the lateral femoral distal angle, and so on and so on. Again, it looks complicated and comfortable. But now, 3D printing, look to the pictures. Anterior, posterior, from the lateral, from the oblique. And look to the 3D printing. And this is the model printed to us. This is the back of the model. You took it between your hands. You rotate it. You have everything you need. You can teach the other guys how to treat it. You can simulate the osteotomy before the operation. Again, you change it, a very sophisticated problem. It's an easy solution. You don't have to draw all these lines. You teach you to draw lines and you make exercises and more exercises. And I bet how many people have solved their deformity problems with these exercises. Again, you have pictures from all around. And this is the model. After we had this model, we imagined, my assistant, they imagined where to do your osteotomy and how to do it. We did transverse osteotomy, and on the model we corrected. We put corticotomy during the operation and put the frame on. Then we do gradual correction of the deformity. And till we have, you see the correction of the deformity, translation to correct the translation. Do we have to correct it with one osteotomy, two osteotomies, and so angulation or resolution, so on and so on. We discussed everything before the operation. And we simulated the osteotomy. And this is during treatment. And you see the translation mode according to our planning. Translation to correct the axis. And till we corrected the deformity. I think this is far easier than the drawing lines. I would like to remind all of you by the CCOT International Meeting in Cairo, 21 to 23. And, you know, the abstract submission had been closed. Unfortunately enough, the largest number of abstracts are coming from India and Egypt. So we expect my Indian friends we have the same numbers of Indian people and the same exactly like the Egyptians. Also, I would like to remind one of you by the Hull deformity course from 20 to 22 June this year in Hull. And for this course, and my friends, we have written a book about fundamentals of lower limb deformity analysis. It's open for free. If you want to download the book, go through to the website of the Hull deformity planning course, and this is the live book. What does that mean? If you make a book, it takes 2 years. So after you finish it, it's old. So we change it. You know, every now and then we change and we update the chapters. So you go to the website and download the book. It's called Fundamentals of Lower Limb Deformity Analysis. The resident surgeons can develop their technical skills depending on the 3D models. It's very important, you know. The problem with deformity planning, they always tell you, you have little experience, you have little experience. Why? Because you have to learn in the operating theater of the patients. But if you have models, you can live, you can do the osteotomies in the models. You can even do gradual correction of the models. Now, we have the model and we build the frame on the model and we do our osteotomy in the model and we let the resident do gradual correction on the model. So you always have a full operation. You have a full treatment using the 3D printing. 4-dimensional printing. I don't know if you have heard about, I've talked to you about 4-dimensional problem. It's a changing problem. It's not a static problem. So 4-dimensional solution. 4-dimensional printing uses the same set of technologies as 3D printing, but adds in one more dimension by allowing the printed part to change shape over time. in response to a specific environment. Although similar to 3D bioprinting, this process uses smart materials to create self-reconfigurable proteins, tissues, organs. Four-dimensional printed objects can self-repair or self-assemble by changing or reshaping their parts in response to varying environmental conditions. People now, with the current time, moving from three-dimensional, five-dimensional, 6 printing technology. It's moving on, it's evolving. It's non-stop process. The concept of 4D printing technology was initially introduced in 2012, showing great potential for application in the field of aerospace, engineering, automobiles, manufacturing, medicine, and many others. 4-dimensional printing is an upgraded version of the commonly used 3D printing, which introduces time as a 4th dimension. Because with time, things will change. We cannot change the implant. We cannot change the implanted material or something every year or something. It has to change itself with response to different mechanical stimuli, chemical stimuli, or something. This is the real future. So fundamentally, the aim of 4D printing is to reconstruct the shape of an object with the use of a smart material, which can change their properties or shapes in response to external stimuli such as mechanical, chemical, thermal, or electrical over time. In orthopedics, the main purpose of these upgraded printing technologies are to manufacture specific tools and devices, intelligent tissue engineered scaffolds, which can release drugs or cells, and smart orthopedic implants, which can change the shape after being implanted in the patient's body. In conclusion, 3-dimensional printing technology will continue to advance and improve patients' care and satisfaction and move to another step forward. Friends, we need a paradigm shift. You have to change your way of thinking from 2D to 3D, 4D, perhaps 5D later on. Move on. Thank you.
Thank you so much, Professor Hosny, for this very interesting presentation. From what I have heard from you and Professor Lalit Maini, I think that beside the educational benefit of 3D printing in all the aspects of orthopedic surgery, I think in the very near future, it will be a fundamental issue in preoperative planning in all aspects of orthopedic surgery, in deformity planning, in arthroplasty, and in trauma management. I think we have all to learn it quite well to do 3D printing before surgery. I'm right, sir?
Yes, this is true.
Thank you so much, sir. We are waiting for questions. And before I receive any questions, I would like to thank Eva Pharma for sponsoring this course. And I would like to thank the team of Eva Pharma, Dr. Mina, Dr. Michael, and Dr. Sameh for their great effort to make this course what we have seen. Thank you so much.
Thank you.
If you have any questions to Professor Hosny? I have a question, sir. The 3D bioprinting and the 3D printing, do you change it? Do you have the option to change what you have decided pre-operatively during the intraoperative situation?
Yeah, definitely, yes, definitely. You can change, you always can change your mind in the operating theater. And we always do this. It's not a static something or something.
Yeah.
But it makes you oriented, you know, it saves time. You don't have to think from the scratch. You know, in your outpatient clinic, you have the patient, you have the reality in front of you. So you think in another model. You know, we used to think how the way we think about these deformities. We always do, we ask the guys, draw the mechanical axis from the center of the head to the center, then measure the lateral distal femoral angle, and this is not reality. It takes hell of a time. And for me, this is far easier. And you have to know, in Egypt, it's cheap. It's not expensive at all. Because people I know in England, I was in England, and it was, it's something like 500 sterling for a case or something. And this is damn expensive here. But it's far cheaper. It's far cheaper in Egypt.
Yeah.
I want to thank Eva for supporting this meeting.
Of course.
Eva is a great pharmaceutical company. I would like Hani also to say something for Eva Pharma, the president of the association. Hani.
I think Dr. Hani is not with us right now.
It's usually our pleasure,
Yeah,
Dr. Gamal.
he's with us now. Yeah, Dr. Hani.
Yes, okay. Firstly, actually, I would like to thank Gamal and also for the very interesting lecture. It is very interesting. And I think 3D or the model is very helpful in management of any deformities. I think it's a very good lecture. Thank you, Gamal. And also, of course, I would like to thank Eva for supporting, and all of Eva. It is a great a big partner to Egyptian Orthopaedic Association. Thank you again, Eva, for your support. Thank you.
Thank you, Dr.
Mohammed. Thank you.
Thank you, Dr. Mina, very much. Thank you, Dr. Mina. Dr. Gamal, we have a question for you from one of our dear attendees. Can 3D printing used for segmental bone loss from bioabsorbable graft printing?
Yes.
Okay, you have a comment on it, sir?
No, it can be done in many situations, like hip dysplasia. In hip dysplasia, it's a complex problem, and sometimes you think you have a lateral deficiency, which is not true. You have a global deficiency, it's a very small acetabulum, things like that. When we started applying it, we were not that sure, just that it can be that effective in the management of deformity. But for me, I think it's going to replace the measurements that we are used to do. When we come to the point that it's easy to make it, it's cheap to make it, it's easy to teach the residents how to deal with this situation, we are going to use it more and more often.
Yeah.
Excuse me, Professor Mohammed, excuse me.
Yes, sir. Dr. Hani.
Okay. Actually, also, it is very useful in foot deformities.
Yes.
In foot deformities, you can attack what do you need, and also attack the deformity and the close the deformity, and also, as Gamal said, that it is very important also for teaching, especially for junior staff. I think it is very important.
And you can simulate the osteotomies.
Yes, yes, of course. And even for your patient, you can explain your patients about the deformity and what kind of operation would you do, and types of operation. And also, it's very it is interesting for the patients, and also useful for the doctors and everything. Okay.
Can I ask one question to Professor Hosny as well as Professor Maini?
Please, sir.
I think one area where it will be very useful is to have a customized 3D printed bone graft available for defects in the bone. Actually, how long do you think this will be available at a reasonable rates? At the moment, I think we'll have to plan it, send it somewhere, they create the bone graft and then send it back, and then that has to be used. But how long do you think it will take for us to print a bone graft, in a hospital and then plant it straight away?
Unfortunately, and in almost my cases, we don't use bone grafts, because we do corticotomy and bone transport in most of our cases. The arthroplasty surgeons who are using the bone grafts in most of their cases. So I don't have experience with the bone graft and the 3D printed bone grafts.
So Srinivas, I can respond to that.
Yes, yes, please.
We've already begun the journey of creating bone graft substitutes, and it's been on for quite a long time. The only change which has happened is the process of doing it. Decades back, you used to have those wedge grafts available for osteotomies, but they were not 3D printed. Now, 3D printing really brings in the possibility of customization and the possibility of material use. So the hydroxyapatite wedges which are available were good for integration, but they won't have the strength. So when you got materials which had strength, they won't integrate well. So now with 3D printing, there is a possibility of composite grafts with bioprinting getting integrated where you can add on biologics to it. So we are on to the journey already. Even in India, we are able, the IIT Mumbai has created scaffolds with surface properties which have the fourth dimension, as Professor have just mentioned, that they would self-repair when integrated into the body. So if you ask me, probably 3 years from now, they would be available. Maybe 5 years from now, they would be commercially viable.
So the printers will be available to the hospitals, sir, in three to 5 years?
No. I don't think this would be done in hospital. Again, it would need to be done at centers which have all the infrastructure needed for creating such biotissues, because it will need level 4 sterility. It's almost like the vaccine creation chambers and those things. It needs the infrared and HEPA filters and all those. So the requirement will go from a surgeon, meaning that the planning part, what he needs, would go as an STL file to the manufacturer, but the manufacturer would be focused at multiple places, and it will not happen in hospitals for sure.
Yes, I have another comment, sir, please. Beside the deformity planning in arthroplasty, especially in revision arthroplasty, if I have an acetabular deficiency, the 3D printing, we used in many cases the trabecular metal augments, the tantalum augments, which have different shapes. So in the 3D printing can guide me what shape exactly I can use from the trabecular metal augments, and I can fashion another shape with the company, the manufacturing company, that exactly can fill the deficient part of the acetabulum in my revision surgery.
Sure.
Professor Ramesh Sen has a comment, sir, I think, or a question.
Yes, please.
You're muted.
So you're muted, sir.
So I just wanted to make a point that being an advisor to Government of India for the scientific development with CSIR, which our Indian police will know, we have been able to get these things done by CSIR lab at my place at Chandigarh, and we have been able to use them, and they have been patented, and soon they are likely to become available to the hospital also, where the requirement will be met by that agency through the government setup as such. The more interesting thing which Dr. Gamal has said, but I just want to add, the beauty of this 3D printing and this is that it's not only the volume which is specific, the kind of a lattice structure which you want within that can also be modified, can also be adjusted micro to macro levels, whatever is specific to that bone level. So it is not only the volume, it is the content also which can be modified beautifully in this technology. And I think these things are likely to be very useful in our orthopedic surgery.
Thank you, sir. Thank you, sir, for your comments. Thank you, sir. If we have any comments from our dear panelists or any questions from our dear attendees. Okay, thank you so much. I think now we have reached the end of our webinar. Finally, I would like to thank our speakers from India, Dr. Lalit Maini, and from Egypt, Dr. Gamal Hosny, for their elegant presentations. also, I would like to thank all the panelists. Special thanks to Dr. Cernives for his great help and great support to make this course real. As you see, the next week we will have another surprise. We'll have two speakers from India. Professor Mandeep will speak about biologics in orthopedics, and from Egypt, Professor Baha Korna will speak about non-union and all the aspects about non-union. It's a very interesting subject to hear. Hoping to see you next Friday at 8 p.m. Cairo local time, 10:30 p.m. Indian time. Thank you so much, and hope to see you next Friday. Thank you so much. Many thanks
you,
to
Lord.
Eva Farman.
Thank you very much.
Thank you. Thank you, sir.
Thank
Thank
you.
you.
Thank you.
Thank you,
Thank
Dr.
you.
Gana. Thank you. Thank you,
Thank
Dr.
you.
Mina. Thank you, Dr. Michael. Thank you, Dr.
Stay
Sam.
safe.
Thank you so much.
Thank you very much. Thank you.
Bye.
Thank you, Dr. Hani. Thank you so much, sir.
Thank you.